So this video is a quick walkthrough of how you send invites using the innovative practice recall system. There's various stages to this, and something you'll probably get very used to, but first time round particularly can be a bit overwhelming because there's lots of reports, lots going on. We have got a spreadsheet on the website that shows a bit more detail about all of these invites. So I'm not going to try and cover everything now, but just give you the broad ideas. So the first thing is this bit: set months of birth that will receive LTC invites shortly. So let's say we're gearing up for sending invites in April. We would put in here probably April, May, maybe June. Let's just take those ones out. So it's basically thinking about patients who need high-risk drug monitoring now, classic kind of methotrexate monitoring, that kind of thing. What you don't really want to do is bring them in for that and then the very next month be inviting them for their annual review. So perhaps going 2 months ahead is about right. And you can't see it there, but you just OK that report. The next two reports, I don't think everyone uses them, but can be useful. So these are the patients who are going to be sent an invite, and you may want to look at the communication needs that are flagged there. Depends a bit how much you code them, how much that's an issue for your patients, but can be useful to run. This report here is for patients who've booked already, and you want to remind them to bring a urine sample when they come. Right, this next section is for all your LTC invites. And again, what you do in this one is you set the months of birth that you want to invite. So again, for April, we would just start with April. What I recommend doing is through the year, keep on adding in months, but leave the early ones. That's because the way the system works, it avoids patients being brought in straight after they've had a recent review. It will cover patients who are newly registered, newly diagnosed, that kind of thing. So up to you, but I would recommend start with April and then keep adding in each month. When that's done, you're ready to run these reports. Now this will look different a bit per practice. This is the kind of initial setup, and this is a practice that wants to do text message invites where possible. So if a patient can be texted, that's the report they're in. The numbers here are really low, partly because it's March and when I'm recording this, and they'll be much higher come the 1st of April. So at the moment it's excluding patients who've had everything done for QOF and things. All the invite report names try to be as self-explanatory as they can. So send first generic letter, and it tells you what code to add. Now I'm not going to actually go through all of this, but I'll show you briefly. So you right click. It's not going to show on there now. Well, maybe you'd view the patients, particularly when you're first sending them. It's worth just sense checking a few, looking at some of the letters, make sure you're happy with them. If you right click further down on here, you can't see it, there's actions, and then you've got print integrated word letters. I would always go for letter to patient. Most practices seem to have that and seem to use it, but perhaps not this one. Let's pick. I can't think what to pick right now, and there's such a long list and nothing that looks really vague and hang on, they've got them in a funny order. Patient referral. Here we go, letter to patients. Okay, that, and then you're searching for the letters. The letters that we've set up for you will either be under standard letters, an LTC, or might be putting them in our folder innovative practice. And the one for this will be annual review letter. I'm going to cancel it and stop that. When it comes up, you then merge and print, and we'd recommend using web posts to send those effectively. And then to add the code, again, actions, add read code, which is at the top, which you can't see, but you would type in that code there. In fact, let me just show you that. Again, I need to make sure I don't actually do that. So you can see the code there, and if we type it in here and tab, you can see what code exactly it is that's bringing it in. Some reports might have multiple codes. So for this one, it's also got this XAMI, and I think it is uppercase I, yes. Unfortunately, in System 1, as you may have realised, uppercase I and lowercase l look exactly the same. Very helpful. So anyway, you would send these, and that you can do this either using the communications annex or just a normal SMS. Some practices we work with to develop options for texting patients with links, texting questionnaires, things like that. Let us know if you'd like to look at that with us. If patients don't respond, or if they respond but then cancel their appointment, that kind of thing, about 4 weeks later they'll drop into the reminder reports. And these can all be sent at the same time, same day. They're not going to overlap at all. The high-risk drug monitoring, I'd recommend sending a following day. And the reason for that is if a patient's been recently invited for their annual review, they will be excluded from the high-risk drug monitoring reports. If they're coming for their annual review, that will cover everything that's needed for their high-risk drug monitoring. Same thing applies for routine monitoring. So the kind of easiest pattern that I would work off is 1 day a month. You might want to do it more often, but once you do that, and then high-risk drug monitoring, I would try and do most weeks, but not on the same day that you're doing generic LTC. The reason just trying to do it most weeks is it just avoids numbers getting too high, it avoids delays. If you've got some of our systems as well that indicate where a patient's not been responding and might need to have their medication reduced to 2 weekly, again, you want to make sure you're on top of these invites. And here particularly, it's broken into highest risk, and then there's kind of one that's everything, and then one that's highest risk. Highest risk is things like DMARDs. The other category will include things like, say, a patient on an ACE who's not had a U&E for 15 months. So because it's such a long time, that's becoming high risk. The way the system's configured here is that the second reminder is always a letter. Letter can obviously put a lot more information in, can warn patients about, we might have to reduce your medication, how important it is to come for monitoring. The letters we set up will automatically put in, you need bloods, you need blood pressure, please bring your urine sample. It will tell them why they need those things. These ones shouldn't have any overlap, and shouldn't have any overlap with the routine monitoring either. Depending upon how your system's configured, routine monitoring will generally include things like 6-monthly HbA1c for diabetics. It will include ad hoc requests that clinicians have put on that are due. It will include things like PSA monitoring, things like that. HP stands for high priority. Again, that's if you've got capacity issues. The idea is you can focus there a bit more on making sure the most important ones are sent. Again, you'll notice down here, and this is something we can develop for practices and sometimes do, is delineating a bit between those who need to call and those who just need blood tests and can therefore be sent a link to book. Again, that's something we can help develop with you if that's something you'd like to look at. We would recommend having a look at the spreadsheet, particularly when you're very first sending some of these. Would recommend just looking at a few patients, look on the recall overview, sense check, make sure it sort of looks sensible, and go from there. Once you get into the run of it, it becomes very straightforward. It doesn't take too long, but when you first start, it can be a bit overwhelming with so many reports. Hope that helps.